Hello. Week two of doing this, still mostly in quarantine for the most part, but again, getting ramped up here at Conceptions. So we had our marketing team post another post for you guys to send us some questions in, and so we have a list of questions that we'll go over this week too. So we'll probably do this again on a weekly basis until things kind of loosen up, so we get kind of somewhat back to normal. So yeah, if you have any questions, please look for those posts and post a question. So we'll get started. The first question we got was, what male factor might inhibit ICSI? Well, really the main thing that would inhibit ICSI is no sperm. So some of our patients are diagnosed as azoospermia, which means you have no sperm. But that's not, it's not a dead end, because then we also work with urologists. We can do epididymal aspiration, and if can't find sperm there, then we go to the testes and get some testicular biopsy, and we can basically culture that testicular tissue and hopefully get some sperm out of it. So I would say that having no sperm would inhibit ICSI. We do have some patients who come through with like super severe abnormal morphology or teratospermia. In those patients, we still usually find enough sperm to inject the eggs, but if the outcome is poor embryo development, sometimes at that point we would recommend those patients do split donor sperm, just so we can compare between the two gametes, or a full donor sperm. So with ICSI, the nice thing about ICSI is, if we can find sperm, let's just say, for example, you have 10 eggs, we just need 10 good sperm. And so men typically have millions of sperm in their ejaculate. So finding 10 good sperm is totally doable. We have some procedures that we can do to isolate that sperm. We have gradient centrifugations. We also have, there's some new companies coming out with some sperm separation slides that we can use to get the best of the best. And so ICSI was created mostly to get around male factor. So if we have some sperm there, we typically can make it work. And if the sperm is not functioning right, we learn a lot of diagnostic information to better serve the next cycle if that's needed. So the next question is, at what level percentage of motility / morphology will sperm donors be considered? Again, like I said, if we can find some moving sperm, with decent morphology, we're good. We really don't need donor sperm. But a lot of, like I said earlier, a lot of options for our patients with low motility, poor morphology is sometimes we do a split cycle where we, if you have 10 eggs, we'll inseminate 10 with the partner sperm and then 10 with donor sperm. So we kind of learn a lot as far as was it really sperm function or is it egg function? So we have a lot of tricks up our sleeve to kind of work with sperm. When we get sperm, compromised sperm samples, that's when our being scientist really goes to work. And so it's kind of, challenging, and but we have really good success with poor sperm quality.
So I think from a lab side, that's all Glenn and his he puts on his science, his science hat that day. From a nursing and doctor perspective, we look at every patient individually. And so we're going to be really upfront with you when you walk in the door if you have a male factor issue. That's a pretty broad category of diagnosis. And so based on that diagnosis, we're going to be really upfront with you on what's going to be best for you to give you the best chances for success in making a healthy embryo. And if we do recommend that you use donor sperm or donor sperm backup, or at least have that on hand just in case, we're definitely going to talk to you about that ahead of time and let you know. But that diagnosis is so broad, and we have so many different tools and so many different resources now that that's kind of going to have to be something that evolves over your diagnostic phase. So
all right.
Yeah.
Next question is, what vitamins would you recommend for good egg health?
So we mentioned this last time, egg health vitamins. We definitely recommend all of our patients take egg health vitamins. They can certainly help. The main ones are going to be CoQ10, acai, those type of antioxidants, as well as vitamin A, C, and E. But what you can do is reach out to your nurse. A lot of you have maybe even a doctor's email. You can reach out to your nurses though and doctors, and they can send you a list of those egg health vitamins. We do utilize several different companies as well for egg health vitamins. One of those that's really been a great resource to our patients is a company called Theralogics. You can go to theralogics.com. They have some wonderful resources there. We work with them really well. We actually have some of their vitamins on hand for patients to try, and they're really inexpensive. So go to theralogics.com. You can also look on our website, and Dr. Green and Dr. Grindler have done a lot of blogs about egg health and egg health vitamins. So definitely a good resource there as well. If you go to our website and look for Dr. Green and Dr. Grindler's blog, you'll find some there too. So.
Next question is, do you have a prenatal vitamin recommendation?
Prenatal vitamins. So we definitely like prescribed prenatal vitamins because those are verified. So you know that the ingredients you're paying for are the actual ingredients in the prenatal vitamin with those. What we're looking for is a prenatal vitamin, and our biggest concern is that you get that 800 milligrams of folic acid. So to be honest with you, if you're getting 800 milligrams of folic acid, you're probably getting a good prenatal vitamin. Your nurses and doctors can recommend some for you. We have prescriptions we can call in to get you. And then again, those websites like Theralogics, they do have prenatal vitamins there too. So that's also a good resource again. So.
All right. Next question. What's the difference between taking Femera cycle day 3 through 7 versus cycle day 5 through 9?
So the question is about Femera, also known as letrozole. This is a medication commonly used in ovulation induction for your IUI cycles. There is no difference in taking it from between days 3 and 5. Okay. The only reason we give that timing is so that we have a wider availability to schedule you for your IUI cycle. But otherwise, there's no difference between days 3 and 5, starting at days 3 and 5.
All right. Next question is a little broad. What will make you determine if someone is more time sensitive than the other?
So this probably is pertaining to the ASRM recommendations, I would imagine. Those patients who are time sensitive. So when you're looking at this, we're looking at and assessing patients based on their age, their diagnosis, certainly their ovarian reserve, their resting follicle counts, AMH. Those are all taken into consideration, for example. But there's a lot that goes into determining who is time sensitive. So, what we're doing internally as a practice is reviewing every patient that calls in or every patient that we have and assessing every patient on a daily basis to make for certain that those patients who are time sensitive, based on criteria, are given the opportunity to move forward as soon as we can. So.
All right. Next question. When seeing a positive ovulation test, how long should you have sex for, after or before?
So ovulation tests, they're not all the same. So it depends on what ovulation test you're using at home. They should have some guidelines written in there, but pretty standardly, we tell patients, to have intercourse every other day. When you get that positive ovulation, you should certainly have intercourse that day and maybe the following day, but every other day is a pretty good rule of thumb.
Next question. How long should I wait between first baby and second transfer?
So our protocol in the office, our general protocol is that you need to wait at least a year before having a transfer after the first baby was born. So we typically don't do a transfer for at least a year after that first one. Something to note as well is that in order to complete the diagnostic tests and to do what we need to do for your FET cycle, you need to wait a full 3 periods after stopping breastfeeding as well. So that's an important thing to consider, is when do you want to stop breastfeeding, all of that. I will say that, again, depending on the patient, sometimes there's some variation there, and we do waive certain things just depending on your unique situation. So it's always best to call about 3 months prior to when you plan on wanting to conceive, so that we can give you those that timeline and those guidelines and start working you up diagnostically and having you talk to doctors. So.
All right. Next question is, what's the estimation on timeline for transfers?
It's looking like we're going to be back up and running by the 1st of June for transfers. So we might even get some transfers at the end of May. So those of you that are starting periods now in April this week and through April, I encourage you to stay in touch with your nurse, call with cycle day 1. If you're taking birth control pills and stopping pills, definitely call us so that we can get you set up. As you know, our protocols are long in nature. So the people that we're setting up now for their transfer cycles are not going to have a transfer until June. So we need you to call us now, and we're working with those patients to work you up and get you going now with your transfer cycle. I will say one thing about that and on that is no one really knows what's going to happen with this, right? So we are setting you up with the anticipation of, that we're going to get these restrictions lifted at the end of April, and things are hopefully going to start resuming back to normal, and we can, kind of all carry on with our lives. But certainly every day things change. And so we are trying to set our patients up and keep you on track. But it's important for you to note that if that changes and if anything is not what we expect and those guidelines are not lifted at the end of April, we have to assess it at that time, right? So just so everybody knows, we will be speaking to you about the potential for if things don't improve, and if that restriction is extended for staying at home, we may have to change that a little bit. So just so everybody knows. But
all right. Last question is, can we use a surrogate if we made embryos before we even knew we needed a surrogate?
Yeah, absolutely. The FDA, it's helpful for us to be able to test your embryos ahead of time. Because the FDA likes us, to make for certain that embryos are FDA eligible. But one of those, exceptions to the rule is when you didn't think you needed to have a gestational carrier and you have embryos and now you do need them. The FDA does acknowledge that. And so there are some exceptions so that we can use your embryos with a gestational carrier. So yes. The answer to that question is yes. So I wanted to speak to you a couple of things really quickly because I spoke to the nurses a minute ago or earlier today, and there was a couple of things that we're hearing from patients. So just wanted to give you guys a couple of things. I know people are asking time frames. I will tell you again, I want everyone to call us with your cycle day 1. Remember that these cycles are dated back by 2 to 4 weeks. So please call us with cycle day 1. If we can get your treatment program going for you and we can get you moving forward, we're going to do that. Okay, and we need you to call so we can assess you. So that's really important. The general concerns that we're hearing is, should I call if I have a natural pregnancy? Should I call if I don't start my menstrual cycle? What do you want to hear from me? And if anything comes up in my in my situation? And the answer to that question is yes, please call. With all of those things, yes, please call. We're trying to continue to treat all of our patients accordingly as we can. So absolutely call us with those. And at very minimum, you're going to speak to a nurse and hopefully we can alleviate some of your concerns, right? So that's really great. Last but not least, we do definitely want to maintain the office and the sterility of this office and prevent exposure in this office. So when you are scheduled for treatment, we definitely want to make sure that you guys understand what the protocol is when you come to the office. And I know we talked about this a little last time, but just so you guys know what to expect when you come here. When you come in, we want you to come in by yourself, no spouses or children, to limit exposure. We definitely want you to adhere to the guidelines of our governor and wear a mask when you come to the office, because you will be coming in contact and possibly close contact with some of our prescribers and physicians and other clinical staff. I have my mom's mask, so these are great. She's an amazing seamstress, and this is totally fine to wear to the office. So bring your masks. We're limited on masks and we need to preserve them for our FET and IVF patients. So if you can bring in a mask, we'd love for you to wear your own mask here. because as you all know, PPEs are not widely available right now. So we're trying to preserve what we have so we can help you in your IVF and FET cycles. We're also checking temperatures when you come to the door. We're asking that you wash your hands and be very clean. And then we're socially distancing and spacing out our schedules so that patients are not in the office at same times. So that way we can kind of keep our social distancing where it needs to be, at a level that it needs to be. So we may not be able to get you exactly the schedule that you want for some of your appointments, but that's because we definitely want to keep you and your family and our pregnant patients and our staff very safe, or as safe as we possibly can. So that's all.
All right. And then as far as anything from the lab, you know, again, we're still here every day. We're doing a team approach. So there's embryology right now, 3 embryologists here a day. So if you have any questions about, if you have embryos with us, if you have any questions or about your genetic results or your, you know, embryo quality, you can call the office and they will transfer you back to the embryology lab, or you can just talk to your nurse and they can, or email your nurse and they can forward us that email, because we want you to get you geared up, getting you ready for your treatment cycle. So anything lab wise, you know, we're still here doing our thing. So until next time, thanks for tuning in, and
Thanks, guys.
stay safe, and we'll
Send
talk
us
to you
your
soon.
questions. We'll see you in a week.
See you later.